Welcome to the deep dive. Today we're taking a look at something that you probably take completely for granted. Like every time you get a simple paper cut,
Oh, yeah, for sure.
right? You get a paper cut, blood is rushing out under pressure, and within just milliseconds, your body has to build this microscopic dam to seal the breach.
It's incredible when you think about it.
It really is. I mean, the reality is that your circulatory system is constantly walking this microscopic tightrope.
Exactly.
It has to keep the blood liquid enough to speed oxygen to your brain, but, keep it just volatile enough to solidify the exact second a blood vessel tears. So today, our mission is to unpack a massive stack of clinical pharmacology sources.
We've got textbook excerpts, clinical Q&As, rapid review notes, all of it.
Yeah, all focused on drug therapy for coagulation disorders.
Yeah.
Basically, we want to completely demystify this system for you. We're looking at what happens when that natural balancing act completely collapses and the powerhouse drugs that modern medicine uses to kind of hijack the system and save your life.
And to really grasp how these drugs work, you have to understand the sheer physical challenge of the baseline system first, which is called hemostasis.
Right, hemostasis.
Yeah, and hemostasis isn't just like a static plug. It's actually a continuous dynamic battle between two opposing biological forces.
Two forces.
All right. So on one side, you have thrombogenesis, which is the actual formation of the clot. When a vessel tears, it physically spasms and constricts to slow the blood flow down.
Kind of like pinching a hose.
Exactly. Then these specialized cell fragments, platelets, they rush in and clump together to form a temporary plug. But a platelet plug is weak. The rushing blood would just wash it away.
So it needs reinforcements.
Right. So
Yeah.
the body triggers this massive cascade of chemical reactions to produce a tough, stringy protein called fibrin. Fibrin basically weaves through the platelets. It acts like a biological cement that hardens and locks the clot in place.
Okay, let's unpack this, because if the body is just dumping rapid-setting cement into the bloodstream, there has to be some sort of mechanism to stop it from cementing the entire vascular system shut, right?
Precisely. And that is the opposing force.
Right?
Thrombolysis. Or clot breakdown.
Ah,
The second the body starts laying down that fibrin cement, it simultaneously releases a protein called plasminogen. And plasminogen converts into an active enzyme called plasmin.
plasmin.
Yeah, and plasmin is essentially biological acid. Its only job is to slowly eat away at the fibrin cement so the clot dissolves right as the underlying tissue finishes healing.
Wow. So you're perpetually hovering between clotting to death and bleeding to death.
Basically, yes. And when this system fails, we see two distinct types of pathological clots. First, you have arterial clots.
In the arteries.
Right, in the high-pressure arteries. These usually happen because of atherosclerosis, where fatty plaques build up on the vessel walls. If one of those plaques ruptures, the body panics. It thinks the artery is torn.
So it sends in the platelets.
Exactly, a massive mob of platelets, and the resulting clot starves the tissue downstream of oxygen, which is what causes a myocardial infarction, a heart attack.
Okay, and the second type operates in a completely different environment, right? The veins.
Correct. Venous clots form in the low-pressure veins, usually in the deep veins of the legs. This isn't driven by ruptured plaques, though. It's driven by stasis.
Stasis, like when blood just sits there.
Yeah, like if you're sitting on a really long flight or bedridden after surgery, your blood gets sluggish, it pools, and when it pools, the coagulation proteins get concentrated and they start inappropriately weaving that fibrin cement.
Wow, just from sitting too long.
Yeah, and that creates a deep vein thrombosis, a DVT. The immediate danger there isn't tissue starvation. The real danger is the clot breaking loose, traveling up through the right side of the heart and slamming into the tiny vessels of the lungs.
A pulmonary embolism.
Exactly, which is frequently fatal.
Man, so we are dealing with a construction site gone wrong. Like, if we map this out for you listening, think of the circulatory system as a massive highway network. A clot is a catastrophic traffic jam, and bleeding is a collapsed bridge.
That's a great way to look at it.
Right, so arterial clots are caused by an out-of-control mob of platelet bricks in the high-speed lanes. Venous clots are caused by an overproduction of fibrin cement in the slow-moving side streets.
Yes, perfectly stated.
So if we want to clear the streets, the emergency response teams, or drugs, have to target the specific material causing the blockage, which takes us to the first class of drugs in our sources, the anticoagulants, the ones that stop the cement factory.
Right. Anticoagulants are our primary weapon against those venous fibrin-heavy clots. And the most famous, fastest-acting weapon in that category is heparin.
Heparin, we hear about that one all the time on medical
Oh,
shows.
constantly. It's what we use in acute emergencies. But it's a massive, complex molecule. So if you try to swallow it in a pill, your stomach acid just destroys it instantly.
Oh, I didn't know that.
Yeah. So it has to be administered parenterally, usually directly into a vein via an IV, or injected deep into the subcutaneous fat layer under the skin.
Okay.
And when given via FIDE, its onset is aggressive and almost immediate. Like, it takes effect in minutes.
But the sources stress that heparin doesn't actually dissolve existing clots. So if someone comes in with a DVT, how does giving them a drug that just stops new cement from forming actually help the massive block of cement already in their leg?
That is a really crucial distinction. Heparin does not dissolve clots. But remember the baseline system we talked about? The body already has that biological acid plasmin trying to eat away at the clot.
Oh, right.
The problem in a DVT is just that the body is laying down new fibrin cement way faster than the plasmin can dissolve it. So heparin works by binding to a natural protein in your blood called antithrombin III.
Antithrombin III?
Yeah, it acts like a catalyst. It hyperactivates antithrombin III, which then rapidly hunts down and neutralizes the enzymes trying to build the fibrin, specifically thrombin and factor XI.
So it basically cuts off the reinforcements.
Exactly. By completely shutting down the production of new cement, heparin tips the scales. It allows the body's natural plasmin to finally gain the upper hand and slowly dissolve the DVT.
That makes total sense. You aren't busting the clot, you're just starving it.
Right.
But shutting down the cement factory so aggressively has to be monitored, right? Like constantly.
Oh, absolutely.
Because the sources talk extensively about measuring the APTT.
Right, the partial thromboplastin time.
Yeah. And this isn't just a random number on a chart, right? It's literally a physical test of the patient's blood, measuring the exact number of seconds it takes for a sample to solidify in a test tube.
It is a high-wire act for the clinical team, honestly. A normal person's blood might clot in a test tube in, say, about 30 seconds.
Okay.
But when a patient is on an IV heparin drip, the goal is to purposefully delay that clotting time to somewhere between 45 and 70 seconds.
Got it. So you want it thin, but not too thin.
Right. We want it thin enough to prevent the DVT from growing. But if that lab value creeps up to 90 or 100 seconds, the blood has lost almost all ability to coagulate. Wow.
Yeah. At that point, just a minor bump against a bed rail could cause a massive internal hemorrhage. So the nurses have to titrate that IV drip up and down continuously based on those lab draws.
Man, that level of micromanagement is fine in an ICU, but you obviously can't send someone home tethered to an IV pole.
No, definitely not.
We need a long-term solution, which introduces the other classic heavyweight in the sources, warfarin. And warfarin is a pill, but its mechanism is completely different from heparin, right? It doesn't bind to proteins in the blood. It goes straight to the liver.
Yeah. Warfarin is essentially a masterstroke of chemical sabotage. The liver is the factory that manufactures the majority of your clotting factors. And to build several key factors, the liver absolutely requires vitamin K.
Okay, vitamin K.
Right. Warfarin is a vitamin K antagonist. It basically blocks the enzyme that recycles vitamin K in the liver. Without that vitamin, the liver simply cannot synthesize new functional clotting proteins.
Wow. But, and this is a big, but warfarin has a massive clinical delay. When you swallow that first pill, your blood is still full of perfectly healthy clotting factors that the liver manufactured yesterday.
And warfarin can't do anything about those.
Exactly. It can't touch them. It takes 3 to 5 days for those existing clotting factors to naturally reach the end of their lifespan and die off. Only then does the patient achieve full anticoagulation.
Okay, but this raises a huge question based on the timeline. If warfarin takes up to 5 days to actually work, why do we use it for someone in immediate danger? I mean, they could throw a pulmonary embolism on day 2 while we're just sitting around waiting for the old proteins to die.
Right, and that's why we never start a patient on warfarin alone during an acute crisis. We use a strategy called bridging therapy, like a relay race.
Oh, relay race? I like that. So heparin is the sprinter who takes the baton immediately.
Yes. We need the immediate protection of heparin, but the long-term convenience of warfarin. So we start both drugs at the exact same time. The IV heparin acts instantly, neutralizing the active clotting factors today.
While the warfarin is like the marathon runner getting up to speed for tomorrow.
Exactly. The warfarin pill goes to work slowly cutting off the supply chain in the liver. We keep the patient on both drugs for several days, and we monitor the warfarin's effectiveness using a different lab test called the PTINR.
Yeah, INR.
Yeah. We want the INR to reach a level where the blood is taking 2 to 3 times longer than normal to clot, usually a goal of 2 to 3. Once it hits that target, we know the warfarin has taken over, and we can finally turn off the heparin the 4.
It's a highly choreographed handoff.
Yeah.
But, I mean, the side effects for both of these classic drugs are pretty brutal. Let's look at the heparin paradox first. The sources highlight a condition called HIT.
Yes. Heparin-induced thrombocytopenia.
Right, and this sounds crazy. You give a patient a heparin to stop them from clotting, and instead, their immune system freaks out, their platelet count plummets, and they paradoxically start forming aggressive, deadly clots all over their body.
It's an incredibly dangerous autoimmune reaction. The patient's body produces antibodies that attack the heparin, but those antibodies also inadvertently bind to and activate the blood platelets.
Oh, no.
Yeah. The platelets form massive microclots everywhere, which consumes all the available platelets. That's why the overall count drops. So if you see the platelet count crash in a patient on heparin, you have to suspect HIT immediately.
And what do you do?
You must stop the heparin right away and switch them to a completely different type of intravenous anticoagulant, usually a direct thrombin inhibitor like argatroban, which bypasses antithrombin III entirely and doesn't trigger those allergic antibodies.
Okay, so that's the heparin danger. But if a patient survives the hospital and goes home on warfarin, they trade the IV for this crazy dietary minefield.
Yeah.
Because warfarin blocks vitamin K, right? So the amount of vitamin K a patient consumes completely alters how the drug functions.
It does, and the sources make a really critical distinction here. Doctors don't tell patients to stop eating vitamin K entirely.
Right.
They tell them to maintain radical consistency.
Consistency. So, like, if a patient usually eats one spinach salad a week, their doctor dials in their warfarin dose to combat exactly that much dietary vitamin K.
Exactly. The chemistry demands consistency. But if summer arrives and that patient suddenly starts eating huge kale and broccoli salads every single day, they flood their liver with a massive surplus of vitamin K.
And the warfarin gets overwhelmed.
Right. The liver restarts the clotting factory, the blood thickens, and the patient could suffer a fatal stroke despite taking their medication perfectly.
That's terrifying.
And conversely, if they stop eating vegetables altogether, the warfarin becomes too powerful and they risk severe internal bleeding. And they also have to watch out for weird herbal interactions like chamomile tea. It's a very stressful way to live.
Which totally explains why pharmacology didn't just stop at warfarin.
Oh.
The sources dedicate significant time to modern solutions. The DOACs, or direct oral anticoagulants, and the low molecular weight heparins. If warfarin is like a blunt instrument shutting down the whole liver factory, these new drugs are sniper rifles.
Oh, the DOACs were a total revolution in outpatient care. Drugs like dabigatran and rivaroxaban, they don't mess with vitamin K or the liver at all.
Oh, nice.
Yeah. Instead of cutting off the supply chain, they just float into the bloodstream and bind directly to the active sites of specific individual clotting enzymes.
So dabigatran physically plugs up the thrombin enzyme, right?
Yes. And rivaroxaban binds directly to factor Ds. Because their action is so targeted, the dose response is completely linear. Patients just take a fixed dose every day, no diet alterations, no weekly clinic visits for INR blood draws.
That is huge for quality of life.
Yeah.
And the same logic applies to the heparin side with low molecular weight heparin, right? Like enoxaparin.
Exactly. Standard heparin is this messy, unpredictable chain of molecules. But scientists figured out how to chemically chop those chains into uniform, short pieces. That uniformity makes enoxaparin's absorption so predictable that patients can actually inject themselves at home into their abdominal fat after, say, a knee replacement. They don't need the constant hospital monitoring, and it drastically reduces the risk of triggering that terrifying HIT immune response.
That's amazing.
But what's really fascinating here is that everything we've discussed so far, heparin, warfarin, the DOACs, it only addresses half the circulatory map.
Right, the venous side.
Exactly. We've spent all this time talking about preventing the fibrin cement in the slow-moving veins. But if the problem is in the high-pressure arteries, if a fatty plaque ruptures in the vessels feeding the heart or the brain, anticoagulants are virtually useless.
Because arterial clots are caused by a hyperactive mob of platelets.
Right. To stop them, we have to switch drug classes entirely and use antiplatelets.
The crowd control for the platelet bricks. Antiplatelets don't care about the cement, they just want to stop the bricks from holding hands. And the undisputed king of this category is everyday aspirin. But aspirin doesn't just coat the platelets, right? It actually alters their internal communication system?
It does. So platelets are constantly circulating in an inactive, smooth state. When they detect a ruptured plaque, they activate, they change shape, they get all spiky and sticky. But to recruit more platelets, the first responders release a chemical signal called thromboxane A2.
Thromboxane A2.
Yeah. Think of it like a chemical flare gun calling for backup. Aspirin works by permanently blocking an enzyme called COX-1 inside the platelet. Without COX-1, the platelet cannot manufacture thromboxane A2.
It can't fire the flare gun.
Exactly. The platelet might get sticky itself, but it can't recruit the massive mob required to form a heart attack-inducing clot.
Here's where it gets really interesting. Aspirin isn't the only antiplatelet. The sources dive deep into a prototype drug called clopidogrel, which targets a totally different communication pathway.
Right.
Clopidogrel blocks the ADP receptors on the outside of the platelet, and ADP is just another alarm signal. But what blows my mind is that when clopidogrel binds to that receptor, it permanently breaks it.
Yes, it's irreversible.
And a platelet only lives for about 7 to 10 days. So once exposed to clopidogrel, that platelet is permanently deaf to the ADP alarm signal for its entire lifespan.
And that irreversibility is exactly why clopidogrel is so highly effective, especially for patients who have just had a metal stent placed in their coronary arteries.
To hold the vessel open.
Right. The body naturally wants to form a massive platelet clot over that foreign metal. Clopidogrel permanently alters the platelets so they just peacefully float right past the stent.
Wow.
But, and this is a big warning in the sources, clopidogrel has a severe genetically driven limitation. Clopidogrel is a prodrug.
A prodrug, meaning the pill itself is completely chemically inert when you swallow it. It does absolutely nothing until it passes through the liver and the liver metabolizes it into its active platelet-blocking form.
Correct. And to make that conversion, the liver specifically relies on an enzyme called CYP2C19. This is literally where human genetics dictate life or death.
Tell me more about that.
Well, a significant percentage of the population have a genetic mutation that makes them poor metabolizers. Their liver produces very little functional CYP2C19. So if you give one of these patients clopidogrel after a heart attack, the drug just passes right through them entirely inactive.
And they get no protection?
None. Their platelets remain fully capable of aggregating, and they remain at massive risk for a second, fatal heart attack, despite taking their meds perfectly.
That's awful.
But on the flip side, you have ultra-rapid metabolizers. They have hyperactive livers that convert the prodrug too fast, that floods the blood with the active molecule, deafens every platelet in the body all at once, and causes spontaneous, severe hemorrhages.
So the exact same pill can act as a lifesaver, a useless sugar pill, or a deadly poison, entirely dependent on the invisible code of your DNA.
Yeah, it's pretty scary.
It's terrifying. But we have to address the worst-case scenario. We've talked about all the ways to prevent a clot from forming. But what happens when the preventative measures fail?
When it's too late.
Right. What happens when a clot has already formed in an artery, completely blocking blood flow to a patient's brain in an acute ischemic stroke? I mean, we can't wait for plasma to slowly dissolve it over weeks. The brain tissue is dying by the second.
Yeah, when vital tissue is dying, we drop the nuclear option. We use thrombolytics. These are the true clot busters, and the prototype here is a drug called alteplase, or TPA.
TPA.
Right, so remember the body's natural clot-dissolving mechanism, plasminogen turning into plasmin.
The biological acid, yeah.
Well, TPA is basically a massive synthetic intravenous injection of the exact chemical that triggers that conversion.
Right.
When TPA hits the bloodstream, it aggressively forces ambient plasminogen to convert into plasmin right at the site of the clot. It rapidly shreds the fibrin mesh, melting the clot away in minutes and restoring blood flow to the starving brain tissue.
Time is tissue, is the mantra the sources repeat over and over. But dropping a nuclear bomb of biological acid into the bloodstream has massive systemic fallout, right?
Oh, absolutely. The risk is hyperfibrinolysis. TTA doesn't just neatly target the bad clot in the brain. It triggers the destruction of every single protective fibrin clot in the patient's entire body.
So if you have a scab...
If you have a healing ulcer in your stomach, it will dissolve that protective scab and you will hemorrhage into your gut. If you had surgery recently, your incisions will spontaneously open and bleed.
Good Lord.
The absolute greatest fear is causing an intracranial hemorrhage, meaning you turn an ischemic stroke caused by a blockage into a hemorrhagic stroke where the patient is actively bleeding out into their own brain tissue. The screening protocols for TPA are arguably the most rigid checklists in emergency medicine.
So what does this all mean for the clinician standing at the bedside when things go wrong? Like, Let's say a patient is on a heavy heparin drip and their APTT rockets to 150 seconds. Or a patient takes too much warfarin and starts coughing up blood. How do you hit the brakes when you've chemically dismantled the body's ability to stop bleeding?
Well, if we connect this to the bigger picture, the core philosophy of clinical pharmacology is that you never manipulate a volatile, life-threatening system without having a reversal agent readily available.
An antidote.
Right. Every major drug we've discussed has a specific chemical undo button.
Let's look at the chemistry of these antidotes, because it's fascinating how scientists reverse engineer nature. Let's start with our fast-acting IV heparin. If a patient is bleeding out on heparin, what do?
We push an intravenous drug called protamine sulfate, and this is pure physics.
Physics.
Yeah, heparin is a massive molecule with a very strong negative electrical charge. Protamine sulfate is a protein with a very strong positive charge. So when you inject protamine into the blood, it acts like a giant magnet. It violently slams into the heparin molecules, binds to them, and forms this inert salt that the body just filters out. The heparin is neutralized almost instantly. But the sources do note a really strange allergy risk here.
Yes, this part was wild. Patients with a severe fish allergy are at a much higher risk for a life-threatening anaphylactic reaction to protamine sulfate,
Right.
which sounds bizarre until you look at the pharmacology history. Protamine is a highly alkaline protein that was originally isolated from the sperm of salmon.
Yep. So the immune system recognizes those proteins and can trigger a massive allergic reaction.
That is incredible. Okay, what about warfarin? If a patient's INR hits 9.0, meaning their blood is taking 9 times longer than normal to clot, how do we reverse the liver blockade?
We overwhelm the blockade. The antidote for warfarin is simply a massive concentrated dose of vitamin K, scientifically called phytonadione.
Phytonadione, okay.
By flooding the liver with the raw material it was starving for, we basically jumpstart the clotting factor factory. But you have to remember the mechanism here. Vitamin K doesn't clot the blood directly. It just tells the liver to start printing proteins again.
And that takes time.
Exactly. That process takes hours, sometimes days. So if a patient is actively bleeding to death, vitamin K isn't fast enough. You also have to give them an infusion of fresh frozen plasma.
FFP.
Right, which provides immediate pre-made clotting factors donated from another human being's blood.
Got it. And for the modern DOACs, we talked about dabigatran, the sniper rifle that plugs up the thrombin enzyme. If a patient is bleeding on dabigatran, what's the antidote?
The antidote is a drug called idarucizumab.
That's a mouthful.
Yeah, idarucizumab. This is a monoclonal antibody. Scientists genetically engineered a designer protein that is shaped perfectly to recognize the dabigatran molecule, swallow it whole, and rip it right away from the thrombin enzyme. It acts as a chemical decoy.
Incredible. And finally, we have to address the reversal for the nuclear option, the TPA clot busters. If you trigger massive hyperfibrinolysis and the patient starts bleeding into their brain, how do you stop the demolition crew?
You administer an antifibrinolytic drug called aminocaproic acid.
Aminocaproic acid.
Yes. It's essentially a chemical wedge. It jams the gears of the plasminogen molecule, physically preventing it from turning into the active, clot-shredding plasmin. It basically freezes the demolition process, allowing the body's baseline clotting mechanisms a desperate chance to patch the leaks.
The level of mechanical control we have over this system is just staggering. And for you listening, understanding the difference between the fibrin cement in your veins and the platelet bricks in your arteries fundamentally changes how you view your own health.
It really does.
I mean, it explains why your aging parents' doctor is so obsessed with their weekly spinach intake on warfarin.
Or why they tell them to avoid chamomile tea.
Exactly. And it explains why a sudden deep pain in your calf after a long flight, especially if it hurts specifically when you flex your foot upward, which stretches the vein around a potential DVT, is a medical emergency that demands immediate intervention before that venous traffic jam breaks loose. That's a positive Hohmann sign, by the way.
Right, and this knowledge really bridges the gap between abstract textbook chemistry and the physical realities of emergency medicine.
Recognizing the mechanisms behind these drugs clarifies exactly why clinical protocols have to be so rigid.
So I want to leave you with a final thought. Pulling from that terrifying genetic twist we discussed earlier with the antiplatelet clopidogrel.
Oh, the metabolizer issue.
Right. We know that a single mutation in your CYP2C19 liver enzyme completely determines if that drug will save your heart or trigger a hemorrhage. It forces a pretty profound question. Are we rapidly approaching a threshold where emergency medicine will refuse to administer standard protocols without first taking a rapid genetic swab?
That's a fascinating concept. Could pharmacogenomics completely rewrite the rules of trauma bays, finally removing all the dangerous guesswork from the microscopic tightrope happening inside your veins? It is definitely something to think about the next time you get a simple paper cut and watch that brilliant, violent chemical cascade seal the breach. Thanks for joining us on this deep dive.